Yale New Haven Hospital is one of 6 centers in the northeastern United States and the first in Connecticut to be designated as a center of excellence by the Hypertrophic Cardiomyopathy Association. Our program is a unique collaboration between nationally recognized physicians and advanced providers in adult and pediatric cardiology, cardiac imaging, electrophysiology, cardiac surgery, cardiac anesthesia, and genetics who are specifically trained to manage HCM. Our clinic and diagnostic services are centered at our main campus in New Haven, as well as several outpatient facilities in the New Haven area. At Yale New Haven Hospital, we provide the latest in non-invasive imaging and other techniques to aid in the diagnosis and characterization of HCM. These techniques include echocardiography, magnetic resonance imaging or MRI, computed tomography or CT, and various forms of stress testing, including SPECT and PET perfusion imaging. Our studies are administered and interpreted by Yale New Haven physicians who are specialists in the field. In addition to my duties in the HCM clinic, I specialize in cardiac imaging.
We know that many patients with hypertrophic cardiomyopathy will develop worsening heart failure from a restrictive cardiomyopathy. And within our program, we pay very careful attention to those signals. And we know that people with hypertrophic cardiomyopathy present differently with advanced heart failure compared to other types of patients with heart failure. We stay prepared to counsel our patients on advanced heart failure therapies such as heart transplantation when the time comes, and for those individuals who would benefit from it. Our transplant program at Yale has grown considerably over the last few years, and many of our transplant patients and transplant recipients have had hypertrophic cardiomyopathy. We have also adopted a lot of newer technologies within heart transplantation to enable our patients to have access to the newest and latest in transplant care and be able to offer transplant therapy to as many patients who may need transplant therapy moving forward. These include options and mechanisms to expand the donor pool so we can offer transplants safely to our recipients who have hypertrophic cardiomyopathy. Our overall goal within our comprehensive program is to make sure that we are able to offer counseling, medical therapy, surgical therapies, and including transplant therapy to all of our patients with HCM.
Our arrhythmia services fall in several groups. First, as you know, for some patients with hypertrophic cardiomyopathy, the abnormalities of the heart muscle can predispose to abnormalities of the electrical system, which causes the heart to go into life-threatening abnormal rhythms such as ventricular fibrillation. This is what causes cardiac arrest, one of the most feared consequences of HCM. We can prevent cardiac arrest by implanting a defibrillator, so identifying patients at risk is critical. Prior research has identified high-risk features that help us identify HCM patients that would be at risk for this type of complication. This risk assessment process is performed with our electrophysiology team together with your primary HCM physician. For those who do need an ICD, our implanters are expert in all types of ICDs, including the tried and true transvenous device, as well as the newer subcutaneous device. And we'll work with you and talk to you to figure out which device is best for you. Another key piece of arrhythmia care for the person with HCM often is treatment for atrial fibrillation, or AF. AF is an abnormal rhythm of the heart's upper chamber that can lead to stroke and decreases efficiency of the heart's pumping, which often leaves people feeling poorly. We have an active AF center led by our colleague, Dr. Jim Freeman, which performs over 400 ablations per year, including many patients with HCM. So our ablaters are experienced both in performing the procedure overall, which can often be curative for AF, and in working with the HCM patient around the special considerations for that group. Understanding the particular needs of HCM patients in terms of anticoagulation to prevent stroke, as well as medical therapy to treat AF, is also key.
We're a moderate-size center, but we do kind of a whole variety of cases. Obviously the kind of a traditional extended myectomy through sternotomy with excellent results, but we've also done a combination with complex mitral valve repairs, as well as using the robotic platform to do myectomies. Our outcomes have been excellent with low pacemaker rates and really excellent functional outcomes and an excellent surgical outcome in relation to the myectomies. We're very proud of being part of HCMA. I think it's one of the most important association that is on the disease process. I think it really and being selected as Center of Excellence for the HCMA is really a big honor, and it's really helped us help so many patients, which really is the most important part of our job.
Surgical myomectomy, or resection of the heart muscle via surgery from thickened areas of the heart by an experienced surgeon, is often the first choice for reducing the thickness of the septum. However, in situations where surgery is not feasible based on specifics of patient anatomy or clinical condition, or in cases where patients have strong preferences against cardiac surgery, a minimally invasive procedure called alcohol septal ablation is another attractive option. The decision to offer alcohol septal ablation, though, is taken after a multidisciplinary meeting of all the specialists involved, where the anatomy, invasive and non-invasive hemodynamic findings, the imaging findings, and patient specifics are discussed in detail. And when we determine that a patient is suitable for alcohol septal ablation, the procedure itself involves accessing an artery in either the wrist or the leg and placing an access port. Via this, smaller catheters are then taken to the heart arteries. A suitable vessel feeding this area of hypertrophied or thickened heart muscle, which is causing restricted flow of blood out of the heart, is identified. And this is the area which is sort of the reason for exertional symptoms among these patients. This is done by simultaneous echocardiographic imaging during the procedure, and we identify a specific vessel which is feeding this thickened area of the heart. When we are certain that we have identified the correct target vessel, alcohol is then injected into this branch of a heart artery, feeding this area of muscle. The alcohol, over time, about 6 weeks or so, causes scarring of the heart muscle in that region, and that in turn leads to reduction in thickness of the heart muscle. That in turn alleviates the symptoms of the patients, and they start feeling better because they are no longer obstructed in terms of flow out of the heart, and symptoms improve and quality of life improves, and patients are able to walk farther and have less chest pain.
As their genetic counselor, I work alongside the rest of the care team to evaluate family history, establish a clinical diagnosis for the patient, offer genetic testing, provide risk assessment for family histories, and consider treatment options for patients with inherited cardiomyopathies. There are many different genes that have been implicated in the development of HCM. And for individuals with HCM who also have a family history of the condition, about 2/3 of the time, we are able to identify a pathogenic genetic variant on testing. And aside from serving to establish the clinical diagnosis for the patient themselves, this can also be helpful information for their family members. And that's because in cases where we are able to establish the genetic basis of the condition in the family, we are then able to provide targeted genetic screening for the patient's relatives, so they can also learn if they may be at risk to develop this condition at some point in their lifetimes. We also work with pediatric cardiomyopathy specialists to help coordinate screening and management for children who may be at risk to develop this condition. Aside from risk assessment and genetic testing, we also provide a lot of education to our patients and their families. When someone has been diagnosed with hypertrophic cardiomyopathy, they often have a lot of questions about the condition itself, the appropriate screenings and medical management, and also the potential risk for their relatives, including their children, to be affected. And the genetic counselor provides education and patient-friendly resources to help answer these questions and help patients adjust to life with this condition. Ultimately, as the genetic counselor within the Yale Hypertrophic Cardiomyopathy program, I work quite closely with the other members of the care team to help ensure that patients and their families have access to the genetic services and support that they require.
Yale is and has been an active center for clinical research in hypertrophic cardiomyopathy. Among recent trials, Yale was a top enroller in the landmark Explorer HCM, which showed the benefit of the myosin inhibitor mavacamten in improving obstruction and exercise capacity in patients with obstructive hypertrophic cardiomyopathy. And Dr. Jacoby, now an adjunct faculty with our program, was a senior author of this paper. Yale has also been an active participant in the SHARE registry, which has contributed many insights to the field, as well as other registries. Live HCM, looking at how lifestyle and exercise influence how people with HCM do over time, which many of you may have participated in, is based here at Yale. The HCMA is an active partner in the study, and of the over 1,700 patients that enrolled, 340 were self-enrolled through the HCMA. We presented the baseline data on activity patterns at the American Heart Association last year. And as you can see, patients with HCM are doing all kinds of things, from sedentary to more active to even vigorous exercise. We're finishing up collecting the data now and should have results by the end of the year. If you entered the study but we've lost track of you, please reconnect. Even if it's been some time, letting us know how you've been doing will help us get the data that we're all looking for about exercise and HCM. Finally, we have a number of other studies, some in the follow-up phase, including other studies of mavacamten, now under the oversight for our site here at Yale of Dr. Stendahl. And we're looking forward to several new studies expecting to start soon. These include trials of newer sarcomere inhibitors, an expansion of the SHARE registry, and use of myosin inhibitors in non-obstructive cardiomyopathy. Thanks to all of you who are and have been and will be participating in research to beat HCM.
Yale New Haven Hospital is a comprehensive hypertrophic cardiomyopathy center that offers advanced diagnostic testing, genetic services, and treatments including arrhythmia management, septal reduction therapy, and novel medications. Our team is proud to be among HCMA's recognized centers of excellence. With support from the HCMA, we can continue to improve the lives of those affected by hypertrophic cardiomyopathy.